Good, guys. Today we're going to have a very interesting discussion on somatoform disorders. Somatoform disorders. What are somatoform disorders? Let's get it in, buddy. Let's get it in. Let's see here. Let me just go to Google and just ask, explain. Explain the assessment and treatment of somatoform disorders. These are complicated. These orders are kind of complicated because the symptom clusters fall everywhere. The patients have an unusual combination of different symptoms, But let me see if I can make this make some sense for you. Assessment of somatoform disorders involve ruling out organic medical causes for symptoms. Before I move to assessment, let me change. They're jumping too far into the story. Explain. I didn't want it to sort all the way to the assessment part. Let me at least give some description. Here, a somatoform disorder, now largely known as somatic symptom disorder, is a mental health condition characterized by one or more distressing physical symptoms. One or more distressing physical symptoms, accompanied by excessive thoughts, feelings, or behaviors related to those symptoms. So, for example, someone can feel that they have a stomach pain or discomfort, right? And it's there nagging at them, right? And they can become excessively preoccupied with it to the point where it seems like they're excessively focused on this sensation to the extent of everything else around them. When they're pulled back into the discomfort and away from other things, then you'll see how that pain or discomfort has sort of like a magnetic pull. It pulls their attention and they continue to focus excessively on that pain and discomfort. The symptoms themselves are real, right? See, that's the key here. The symptoms are real. It's not imaginary, right? But they are often disproportionate to the underlying medical condition, or a medical condition cannot be found, right? This is very complicated. So people come in with pain, but then you can't find a explanation of it, or they no longer have the medical condition, but they still have the pain associated with the medical condition. Yeah. It creates a functional impairment because these symptoms and their health concerns, functional impairment, they can't function at work. They have difficulty functioning in interpersonal relationships, have a lot of difficulty functioning. Key characteristics of somatic symptom disorder. Physical symptoms. The individual experiences a real physical symptom such as pain, weakness, or shortness of breath. The key is that the pain and discomfort is real. They're not lying, right? It causes distress and dysfunction. The symptoms cause significant emotional distress and interfere with daily life, right? Excessive thoughts and feelings and behaviors. The person has excessive thoughts about the seriousness of their symptoms, high levels of anxiety about their health, and spend excessive time and energy on health concerns, right? Yeah, this is a significant part of that. These symptoms may or may not be medically explained. The physical symptoms may or may not be associated with a diagnosed medical condition, but the person's reaction to them is the main problem, right? Not faking. The person is not intentionally faking their symptoms. The pain and other symptoms are genuine. So remember, in somatoform and malingering, there is a benefit, right? So the benefit is they want to stay in the hospital, right? So they can produce pain that sounds like this. In that situation of malingering, they're lying, right? I'm doing a series on narcissists, and and trying to help people understand that when there's sick narcissists in front of you, that's a clown, and you're actually dealing with a whole network of idiots. So when you're dealing with a narcissist, when they target you, they play the victim role. And oh my God, they come up with pain everywhere. Ooh, ooh, ooh. When the narcissist plays the victim, boy, I mean, they fake pain everywhere. And it's all dramatic. It sort of pulls you into their suffering as they develop the victim narrative of how much they've been victimized and things like that. Um, so narcissists and like people who malingering, they're lying, but not somatoform. These are real. What is no longer used to describe this condition? Yeah, historically, terms like somatoform disorder were used, but the terms has been updated to somatic symptom disorder. Yeah, 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 somatic symptom disorder. You're going to see some of the nomenclature sort of change and updates as we learn more about these disorders. This somatic symptom disorder makes it, the label suggests that these are real symptoms, not a form of a disorder, but a real disorder. The name sort of suggested malingering, right? Specific previous conditions like somatization disorder, undifferentiated somatoform, hypochondriasis, and pain disorder now incorporated under a new umbrella of somatic symptom disorder. They put all these. I did go back and look at the podcast I did on pain, primary pain disorders. These are something else too to treat. That pain is real too. So look, I'm gonna go back and update. I have to go back and update my titles. Let me see here. Let's see if I can do it now. Okay, somatic symptom disorder. I just updated it. Yep, somatic symptom disorder. Okay, let me see where I'm at now. Okay. Oh, potential causes: difficulty processing emotions or a tendency towards negative thinking patterns. Now, it just so happens that one of the primitive defense mechanisms is somatization. Let me see. Defense mechanisms is how your ego defends itself against things that's threatening them, how your ego responds and interprets things. And one of the primitive defense mechanisms, I believe, is called the somatization. Let me see if it's self-asserted. Okay, mature defenses, neurotic defenses, immature defensive. Okay, look, immature defenses here, immature, depressive, passive aggressive, help rejecting, complaining, acting out, splitting, projection. I was looking for the defense mechanisms that would possibly make the person susceptible to the somatoform type disorders. Somatoform, I gotta get the name right, to a somatoform disorder, but I couldn't find it. So here, so potential cause is difficulty processing emotions. And so what happens is that people who use primitive defense mechanisms typically suppress their most intense and difficult urges and things like that. All the things that people cannot handle, they have a tendency with the primitive defense mechanism to suppress them out and repress them to outside of existence. Now, because they're not consciously aware of these issues, or they can't consciously deal with the trauma or the hurt, the pain, the rejections, the stab in the back, then they repress it, but it comes up as physical pain and discomfort, right? So someone who's been sexually abused may have GI or urinary symptoms or GI symptoms that represent sort of like the discomfort and the trauma of what you experience. And so not being developed healthy or not maturing enough and having the appropriate defense mechanisms, then it's more like a setup to be having a somatoform type disorder, because it's hard for you to process things. And so people process things, they feel it in their body. So these things are real. A tendency toward negative defending patterns. Really, the primitive defense mechanisms are black and white, either all good or all bad. Here we are right there. Environmental factors such as childhood trauma, abuse, neglect, being around sick people. Now, look, these people with somatoform disorders, if they are around sick people, such as narcissists, psychopaths, and sociopaths, they accentuate the pain. They create so much chaos around them with targeting them, with attacking them through third parties, with starting reputations. Can you imagine somatoform, someone with a somatoform power disorder being around or being attacked by a bunch of group of narcissists? Yeah, and see, look, the environmental factors, usually there's a childhood or surrounded by people who devalue them. They're surrounded by people who spread rumors about them, all these things. It's a tremendous amount of psychological and emotional abuse associated with patients experiencing these things. Cultural attitudes towards physical symptoms and medical care. What do you do if you suspect it? Okay, yeah, seek medical care. Okay, so this is what we're talking about here. Somatic symptom disorder. I have to remember that. If I'm going to teach it, I got to remember the name. Okay, now here's the one on the assessments. And let me know if you have any questions. Let me know. You can just type them down in the chat section. But here, let me go through the assessment. See, the assessment for somatic symptom disorder involves ruling out organic medical causes, right? Both psychiatric, right? Remember the psychological, emotional abuse, trauma, reacting to emotional, psychological abuse, and medical histories, and performing physical and mental status exams, right? The physical exam, look for the medical problems, right? Mental status examination, you're going to know whether the person has a delirium, a psychosis, or mania. And this you're going to pick up from the mental status examination. Treatment focuses on daily functioning and coping skills using regular supportive visits with a primary care physician to build trust. The person likely doesn't have trust outside of their home, right? So that's why being a physician is very important, because your role is to trust your patient, right? Right, and this is where they get the trust from. Effective treatment includes psychotherapy, right? Because you're going to need some help you're going to have to identify all those sick people around you. I'm not sure if you can get better if you're surrounded by sick people. That's why narcissists always have to go to people around you and talk about you behind your back, right? Narcissists are psychopaths and sociopaths are trying to create a community against you. That's why they always have to say things in secret and hide. These creeps, they're awful. Cognitive behavioral therapy to manage thoughts about health and symptoms. Okay, assessment. Rule out organic causes, right? Gather medical and psychiatric history, right? This is most important. Build a therapeutic alliance. Establishing trust and empathy with the patient is crucial. Acknowledging their discomfort, and validating their symptoms. In the pain, the discomfort in the somatoform disorder will likely have two components. One, it'll likely be the physical pain from the underlying condition. And then, number one, the psychological pain or discomfort associated with it. And many times, the psychological component inflames to the point where it becomes the predominant symptoms. The depression, the anxiety, the insomnia, the fits of mania, the fits of rage, the psychoticism, all of those can be the result of the psychological component not being managed as well. That's why it's important that we do a mental status examination and start to look at other areas, to look for other areas that may not be functioning as well. And those are the areas where we can sort of design our treatments. So we have to look at the person's attention and concentration. If they can't pay attention and concentrate, we have to give them something to support their cognitive functioning. If they're very depressed, we have to report the depression. If they're manic. If psychotic, we have to report psychoticism. So you're going to have to build a therapeutic alliance, right? So they can validate their symptoms and then help try to identify all the different areas they're having difficulty in and start addressing those areas, right? So that's when your multidisciplinary treatment team comes up. That's when your psychologist, your therapist, all of these other treatment team, social worker, all these other treatment team members come to help with this. Screening. Specific screening tools can help you determine the presence of a somatic symptom disorder. Let me just see screening tools. Okay, they just said it. They don't offer anyone. If someone knows a screening tool, let me know. Treatment, regular supportive care, psychotherapy, psychopharmacological approaches, avoid narcotics. This is going to be this is endurance here, lifestyle intervention. I would encourage anyone I'm not sure what's more damaging to you, a riot outside or having to work next to a narcissist. I think if you're working next to a narcissist, you're going to need some type of lifestyle intervention. If you're living or working next to one of these sick people, I think you're going to have a hard time. So lifestyle interventions is something called the geographic cure. You simply leave and you never walk back. You never look back. If your pain, if you leave and your pain goes away, listen. The longer I practice psychiatry, the longer I start to know it's the people around you. Oh no, it's the enemy is not far. It's the people around you. And these narcissists, psychopaths, and sociopaths, they specialize in trying to be your friend, and they create all the internal turmoil that causes you emotional, psychological pain. So here, it's hard for me when I look through patients with somatoform disorders littered with narcissists around them. Mom was a narcissist, dad's a sociopath, all of this. Focus on functional goals. The functional goals are the only way you're going to help these people out of this, right? You're going to have to count the numbers. I mean, how many times you worked out this week? Got to work out once a day. How many times you avoided sweets and things like that? How many times you're fasting, or how many times you go into church and get into your routine? Yeah, these things, the goals that they have to set. Make sure you go to church every Sunday. No, you're going to have to be the first one there inside the chapel or the mosque or wherever you pray at. You have to be the first one in there, right? Functional goals like that. Things like hygiene. You're going to have the best hygiene. I mean, every day you're going to have the best hygiene. Focus on goals like that. That'll help them build their lives and get the motivation to get out of there. Patient education. Helping people understand the origin of the pain and the discomfort and things and what does it mean. It could be a flashback, right? It could be like post-traumatic stress disorder flashback. It could be something like that. Number of things. So, hey, let me give you a question. Hey, Muhammad, how's it going, buddy? Thanks for your question, bro. Let me see here. Can cognitive behavioral therapy truly help these patients? Yes. Right. Let me see. Cognitive is what you think. Behavioral is how you behave. That's what I said. Behave. Walk away. Cognitive. Never think about it again. Solves every problem. Me. I'm not the type of man that fight. I'm the type of man that run. You don't have to win every fight. You only have to win the last one. I'd rather win the last fight and rather run. Right. So CBT is very helpful because the cognitive pieces help you detach from the things that you're attached to, right? And the behavior things help you behave differently and mainly use that behavior to not go there again. That's it. I think that's all that I have for today. It's been a pleasure talking to you guys. Somatoform. So remember this. Let me make sure I have it right. Should I have it right? Okay, yes, somatic symptom disorder, treatment and assessment. And basically, you're going to treat whatever you have. If it's mood disorders, use mood disorders, anxiety, SSRI, psychosis. You know the spiel. Read out. Take care, guys. Check it out. Ciao. How's it going, everybody? Today, our discussion is on negative symptoms, particularly negative symptoms in schizophrenia. Now, we can trace the symptoms of schizophrenia back to a network referred to as the mesocortical pathway. Overactivity or hyperactivity of the mesocortical pathway is associated with positive symptoms of schizophrenia. Let's look at some of those positive symptoms here. Let's see here. Let's see. Name the positive symptoms of schizophrenia. And again, do I have to sign in for this? Well, I think I used up my my free subscription, my free things. Let me go here. Okay, I don't want, stay signed out. I don't want anything free. Okay, how about explain the positive symptoms of schizophrenia. Oh, it's not available for okay, it's not available. Okay, we should be able to get them real quick. I'm gonna accept this. Okay. Positive symptoms reflect hyperactivity in that mesolimbic pathway. And hyperactivity and the positive symptoms are typically auditory hallucinations, delusions, or disorganized thoughts or behaviors. And the hallucinations can be either auditory or visual. They can also be tactile. The delusions can be bizarre delusions for things that are just absolutely not possible at all. Versus non-bizarre delusions, meaning it's a possibility, but probably not likely. So hallucination, delusion, and then disorganized thoughts or behaviors. Sometimes the person cannot express their thoughts in a coherent and logical manner. Sometimes they won't be able to filter their thoughts, and so things come out at the same time. And so the thought process, the structure of the thought is disrupted, and you sort of listen to it and it sounds disorganized. So the positive symptoms reflect hyperactivity in the mesocortical pathway, and it can result in hallucinations, delusions, or disorganization, right? Now, the hyperactivity occurs because you have excessive dopaminergic activity. Yep. Excessive dopaminergic activity is the too much dopamine story that drives this entire issue. Let me show you where that's happening at. It's taking place here at the synaptic cleft. Right here. Let me see if we can find it here. Right here. I hope I can blow this up. Yep. Great. Here's one brain cell, and here's another one. This is the presynaptic cell, and let's say this is the postsynaptic cell. Well, actually, the receptors are on this side, so I guess this would be the presynaptic since the receptors over here, and this would be the postsynaptic. Okay, if this is a presynaptic cell, then dopamine is released from the presynaptic cell into the synaptic cleft, and it binds to the receptor on the postsynaptic cell. Remember, this is a G protein. So when this cell G protein complex is activated, it sends instructions to the cell body to produce things, right? Likely more of itself. So the increased binding of dopamine to the postsynaptic receptor creates more dopamine that's eventually stored in vesicles, and they wait for the next release, right? So can you see this feed-forward process whereby dopamine is excreted from the presynaptic cell, it goes across the cleft, it binds to this postsynaptic cell and eventually results in the production of more dopamine that's stored at the end of that cell to that postsynaptic cell to get ready for the next signal to be released. When this process is turned up, you get hyperactivity on that network, and therefore you get hyperactivity in the mesocortical pathway, right? And then you get the emergence of the hallucinations, the delusion, or the disorganized behavior. Does that make sense? But it's all a dopamine hyperactivity story. Now, this discussion is about negative symptoms of schizophrenia. And what am I saying with negative? This flushing out of dopamine from the presynaptic cell only lasts for so long and it poops out. When there's no more dopamine, the whole network becomes hyper, it starts to slow down. And because you're in a relative depletion of dopamine, everything becomes hypoactive. Now, in the presynaptic cell, there's no more dopamine to be released. And therefore, there's less dopamine in the synaptic cleft, meaning there's less dopamine binding to the postsynaptic receptors, meaning that less activity across the entire mesocortical pathway. Dopamine hypoactivity is the results in hypoactivity in the mesocortical pathway. And when we get hypoactivity in the mesocortical pathway, we get a certain cluster of symptoms associated with that. Let me look here and see if I can find the list. So list the negative symptoms of schizophrenia. Glad I got an AI back. Okay. The negative symptoms of schizophrenia are a loss or deficit of normal behaviors or abilities, distinguishing them from positive symptoms, which are in excess or distortion of normal function. Remember, think of it turned up to the radio turned up too high, too much excitation, noise. First thing that goes down are your sensory experiences. Start seeing things that's not there. Next thing goes, start believing things. And then after that, you start sort of becoming disorganized. So you keep turning the thing up until things fall apart, right? Ride till the wheels fall off, I guess that's called. And so the exact opposite, hypoactivity, are a lack of symptoms, right? A lack of symptoms. Okay, look at here. Okay, this is interesting. They can be divided into two main categories: diminished expressions and a motivation. Yeah, let me see what this says here. This may be interesting. I think I want to get the free stuff. I want the free stuff. I want to go in and get the free stuff and get on out. Symptoms of schizophrenia. Okay, positive. We remember the excessive amount of hallucinations and delusion, and then they do have disorganized behavior here. Okay, positive disorganized symptoms. Okay, disorganized thought. Yeah, disorganized speech here. Yeah, disorganized thought. Disorganized behavior. Negative symptoms. Look, popular speech, right? Flat affect, not moving much, right? Poor attention, meaning not as aware. Look, loss of motivation. Remember that mesolimbic pathway is the reward center, right? And many times, if you have a hypoactive mesocortical pathway, if you have dopamine deficient, if you're dopamine deficient, that means that all the pathways that's dependent upon dopamine will be hypoactive. So that means the mesocortical pathway will have the negative symptoms of schizophrenia, right? The mesolimbic pathway is your reward system. So when they take cocaine and it causes the release of the presynaptic dopamine, it gives the high and everything, but then there's a burnout. And then when the mesolimbic system, mesolimbic pathway is hypoactive, then no interest, no motivation. Look, loss of interest, lack of motivation, loss of drive, sort of like apathy, look, lack of pleasure, right? That's the exact opposite of the mesolimbic pathway. lack of social attention deficit. Yeah, and so these are the negative symptoms of schizophrenia. You know, and if you think of it, if the mesocortical mesolimbic pathways are hypoactive due to very little dopamine, then that means that the person's um, brain is simply not producing enough of the materials it needs to sort of run the network well. That makes sense. So there's like a deficit. So you need to produce things, right? So if you're not having enough dopamine, you need to produce things. So you need to get instructions to the cell body to start producing these things in order to get your appropriate neurotransmitter levels to run these networks appropriately. Um, hope that makes sense. Okay, so remember, Haldol blocks dopamine receptors, right? And so, why would you give a antipsychotic medication to a person who's having negative symptoms if the assumption is it's a hypodopaminergic state? So if they don't have enough dopamine, you mean you're gonna block more dopamine receptors? Hey, we'll go through that over. It's a concept called modulation. They're modulators. So it's a different class of receptors, and we'll sort of go through that a little later. But let me go through, do a literature review on the treatment of negative symptoms. And to be honest, I always feel not uncomfortable. I always feel nervous. It takes so long for these symptoms to improve. It's like you kind of want to have some control over the process, and you don't know how long it's going to go, on. And so I wanted to just go, express that there are some conditions that I do treat as a physician, and you're going to encounter these too as a physician, that you sort of need to go back to the literature and sort of keep looking at this thing over and over and everything until you get here's 20 something years and still look at negative symptoms with a lot of respect and regard, because it takes a while for these symptoms to improve. The positive symptoms can improve right away because you're just blocking the hyperactive networks. You're just blocking everything and taking up the seats on the train, right? So that you can't fill up. And so blocking is easy. And so that's when you get resolution of the positive symptoms a lot easier. But the negative symptoms, you may have to produce things, a lot of things. And that's the hard part. So let me go to Google Scholar here. So the pharmacological treatment of negative symptoms schizophrenia. Let me just look at a few articles. Look, drug treatment of negative schizophrenia. Okay, pharmacological treatment. Okay, pharmacological treatment. Okay, systemic review, pharmacological treatment. Okay. Addressing the unmet need of patients with persistent negative symptoms of schizophrenia, emerging psychological treatment option. Okay, so let me see here. Okay. Remember, we getting free. Getting free. Jump it in, jump it out. Okay, let me see here. Drug treatment of the negative symptoms of schizophrenia. The traditional antipsychotics are generally poorly effective or ineffective against negative symptoms of schizophrenia, and are also associated with extensive side effects, which can themselves cause or exacerbate secondary negative symptomatology. Wow. Yeah. This seems like it expressed all my fears, as well as having a low propensity to cause EPS. All right. The currently available putative or typical antipsychotic clozapine, Risperdal. Yep. Okay. Yep. developmental antipsychotics, okay, and low dose of certain traditional antipsychotics, okay, have been reported to ameliorate negative symptoms and compared with placebo. Okay, okay, some of these have been shown to be effective. Okay, they have been reported to ameliorate negative symptoms in comparison with placebo or standard. Okay, all right, so okay, although okay, to date, few trials have specifically examined the primary negative symptomatology, and it has been suggested that the improvements observed in these drugs may be related to decrease in positive symptoms and a reduction in EPS symptoms. Hold on a second. Okay, let me see here. Okay, to date, a few trials have specifically examined primary negative symptomatology. Okay, right. And it has been suggested that the improvements observed with these drugs may be related to decrease in positive symptoms and or reduction in sedation or EPS side effects. Oh wow. Okay. So basically, yeah, you're reducing side effects and EPS symptoms. Has, um, although a typicality has been ascribed to 5-HTD2 antagonism, the exact pharmacological mechanism underlying the efficacy of the atypical antipsychotics have not been elucidated. I thought it was. Okay, well, anyway. All right, let me just go to what their findings are. Okay, conclusions. Okay, the use of low dose antipsychotics and negative symptoms. Okay, although in the majority of studies, the classical antipsychotics had low efficacy against negative symptomatology. Reports over the last 10 years have suggested that they may have been more effective at low doses. This is consistent with animal studies' facilitation of dopaminergic transmission at low doses compared to inhibition at higher doses currently used clinically. Among the drugs for which a good dissociation between dose stimulation and blocking dopaminergic transmission has, oh, it says that. So it's saying low dose is the pharmacology of atypical. Yeah, because remember they have that broader receptor profile, receptor binding profile. Several theories have been put forward to explain both the improved tolerability and efficacy of atypical antipsychotics against negative symptoms, and the combination of the anti-serotonergic component with dopamine antagonism. Yeah, was first proposed in 1989, which one of the widely quoted. However, the effects on the neurotransmitter also be important in the clinical profile of the atypical antipsychotics, that these are different between. Okay. um, Here, the results of the trials of antipsychotics discussed above suggest that these drugs are superior to traditional antipsychotics in the treatment of negative symptoms. So yeah, we were typically using the typical antipsychotics like Haldol or some things like that for the negative symptoms, but they're saying atypical dose and low doses. However, since negative symptoms may be secondary to EPS symptoms, positive symptomatology, depression, or sedation, and in the majority of trials, such as secondary negative symptoms were not differentiated from the primary negative symptoms of the disease. I didn't know there was a primary and secondary. I didn't know there was a primary and secondary negative symptoms. So, so I guess they're saying that the patient present with psychomotor slowing, psychomotor retardation, and things like that. It may be a more complicated story because they could be having side effects to the medications. It could be extrapyramidal side effects where they're having movement disorders that's produced by the treatment. And so I think they're saying that low dose antipsychotics may ameliorate some of those symptoms, and therefore it may appear as if the patient's negative symptoms improve, and really you're just getting rid of the side effects of other medications. That's very interesting to know. Um, let's say, although it has been claimed that the newer atypical antipsychotics have improved efficacy against the negative symptoms of schizophrenia when compared with standard antipsychotics, evidence for an effect independent of an improvement in positive symptomatology and of EPS symptoms is poor. Right. The pharmacological profile responsible for improvement in efficacy has not been elucidated, but it is certainly likely that the only one receptor so far that unlike, but it seems unlikely that only one receptor subtype mediates all the atypical effects, meaning that the neurotransmitters responsible for creating this are probably a combination of not just one neurotransmitter. So let me see here. Pharmacological treatment of negative symptoms schizophrenia here. Pharmacological treatment of negative symptoms schizophrenia, therapeutic opportunity or cul-de-sac. Okay. Negative symptoms of schizophrenia are debilitating, and they contribute to poor outcomes in schizophrenia, right? Initial enthusiasm that second generation antipsychotics will prove to be powerful agents to improve negative symptoms have given way to relative pessimism. That the effects of current psychological treatment are at best modest. So they're saying that they overstated the efficacy of the atypical antipsychotics and low dose, particularly, and treating negative symptoms. Okay, the method, a review of current state of play of pharmacological treatment for negative symptoms of schizophrenia. Treatment results today have been largely disappointing. The evidence for efficacy of second generation psychotics is reviewed. Conclusion: the measurement and treatment trials methodology for the evaluation of negative symptoms need additional refinement before therapeutic optimism can that better treatments for negative symptoms can be realized. You see how, it's amazing how they say basically say it don't work. They're saying the evaluation needs additional refinement before therapeutic optimism that better treatments for negative symptoms can be realized. It's interesting how they said that. Negative symptoms are disabling, difficult to evaluate. Yeah, difficult to evaluate. Treatment thus far have at best modest impact upon negative symptoms, especially for primary negative symptoms. I think it's probably a good idea to start explaining this more, using more education to sort of explain this, because looking at this literature again, I think I'm not the only one having challenges with treating negative symptoms. So introduction. Negative symptoms of schizophrenia are core components of schizophrenia that unfortunately remain largely recalcitrant to current treatments. Yep. So here, what are negative symptoms? Dysfunction of communication, alogia, poverty of speech, talks little, uses few words. Listen, dysfunction of affect, blunted affect, reduced range of emotions, perceptions, experience, expressions, feels numb or empty inside, recalls few emotional experiences, or feel good, bad, feels good or bad. Either good or bad. Let me explain something here. Look at this blunted affect here. So it not only has to do more with your facial expressions, like here, your expressions here. It also has to do with like your perception, right? Look, your experience, right? You ever been engaging with someone and they're simply locked in a certain perspective, right? They're locked on a certain focus. That's that not only is the facial expression may be limited, but their ability to jump off the subject may be eliminated. They may not be able to jump off the subject because they have that restricted affect, and so they can only recall restricted experiences or have restricted certain types of behaviors. So they can only engage with you in a certain restricted way. You see someone who's been traumatized can only engage with you in a traumatic way until they find some way to recover from that. Does that make sense? It's not like someone who's traumatized treats you with kindness, and it seems like they're in the crisis, and it's simply that anger, the energy is typically directed at outward at the time. So here, look, dysfunction in socialization, asociality, reduced social drive and interactions, little sexual interest through friends, little interest in spending time with others. Yeah. Dysfunctional capacity for pleasure, anhedonia, reduced ability to express pleasure, right? Dysfunctional motivation, avolition, reduced desire, motivation, persistence, reduced ability to undertake and completely take any new allergies. Okay, so let me see their conclusion. Okay, what was their conclusion? Let me see here. Okay, they basically the study says that um, there's really not enough evidence that says atypicals work better than typicals, so you should just be careful with it. Pharmacological treatment of negative symptoms. Let me see here. Okay, so pharmacological treatment. Effective treatment of negative symptoms is one of the most important unmet needs in schizophrenic disorder. Yeah, because the evidence on current psychopharmacological treatment is unclear because the evidence on current psychopharmacological treatment is unclear. The author reviewed the findings published to date by searching PubMed with the keyword negative symptoms. And that's the end of that. That's the end of that article. It's free, you know. So we're here at the 27-minute mark. I think that's all I have for now. I think you get the point. You get the point. Hey, iHash, how you going, buddy? So let me see here. Okay, how's it going for you, iHash? Thanks for the comment, buddy. Which rating scales and bedside assessments are most practical in outpatient settings? I use the Schizophrenia Assessment of Negative Symptoms scale. It's called the SANS, SANS, and it has all of those domains we talked about. Yeah, I wish I could show you now, but I don't have. Let me see. Yeah, I can go over here. Symptoms. Yeah. Okay, scale for assessment of negative symptoms. Yeah. So this is the scale that I use here, right? Okay. Do they have the actual scale here? Yeah. So the scale basically causes you to rate things in these 5 areas. And so that's what I use for it. You see. Okay. And I think that's all I have for today. All right. So if you have any other questions for me, feel free to like, subscribe, and share, or put the question in the comment section. I'll see if I can get back to you with you. It's a pleasure talking to you guys. Take care, guys. Ciao.